Hi, this is Julie Levinsky. I am the web manager for the Christopher Dana Reeve Foundation, and I'd like to welcome you all to this month's live chat with Nurse Linda. She has been a leader and a provider of rehabilitation nursing for over 30 years and a friend of the Christopher and Dana Reeve Foundation for close to 20. Soon after Christopher was paralyzed, she worked closely with him on his recovery. And now she is a moderator for us in our Ask a Nurse discussion, which is on our online paralysis community, and where she focuses on contributing functional advice, providing the how-to and integrating various healthcare improvements into daily life and answering your questions. And we are lucky enough to have her here live once a month, web chatting it up with us and answering your questions as we go. And I want to remind everybody that you may ask a question in the chat box. And please, if you would like, if you're on the phone, you may dial *1 on your telephone keypad, and the Ready Talk operator will put you through, and you can talk live with Nurse Linda that way. So now I'd like to turn it over to Linda. Hi, Linda.
Hi, Julie. Hello, everyone. It's so nice to be with you today. There's a lot of things going on. Today's topic is to talk about complications. Although we already have some questions in the chat box, so we'll get to those in just a few minutes, because I wanted to start talking this morning about the norovirus. If you've had your TV or radio on, you've heard about the norovirus. It comes about this time of year in the winter time. It's not uncommon for people to get norovirus. But the reason why it's on TV and why we're hearing so much about it right now is because it's come on extremely strongly this year. There's a lot of norovirus going around. So sometimes people misconnect norovirus thinking it's the flu, but it's a different kind of virus. However, the interesting thing about it is that the symptoms are usually the same. So if you have the flu or if you have the norovirus, you end up with quite a few of the same complications and issues. So the norovirus, you can get that virus within 1 to 3 days after exposure. Usually people will get it in 12 to 48 hours when they've been exposed. It's a virus that spreads by touching things, so not so much through coughing and breathing, but by touching different things. So if somebody has the norovirus, it's on their hands, and they touch a pen, and then you pick up the pen, or you go to the grocery store. Somebody with the norovirus has touched the handle of the shopping cart, and then you touch the handle of the shopping cart. You're probably going to get the norovirus. So it's out there, and it's just everywhere with us now. So what is the best thing you can do to keep from getting the norovirus? Well, the first thing is just wash your hands. Wash your hands all the time. You might be needing to have some emollient lotion, because after washing your hands they can become very dry and cracked. But if wash your own hands, have your caretaker wash their hands, have family members wash their hands, and when the kids come home from school, the first thing they should do before they stop and give you a hug is go into the bathroom and wash their hands. And then be sure that the bathroom water handles, the tap handles, are kept completely clean at all times too. So sometimes people have the norovirus on them. It's spread through mostly through vomit and stool. And so, you think, well, people wash their hands, sometimes not just thoroughly enough, or perhaps they didn't use warm enough water and soap. This is a virus that is not affected by hand sanitizers. So if you have a hand sanitizer that's 90% alcohol, we usually can say you can substitute that for good hand washing. But in this particular virus, hand sanitizers does not kill this virus. So if you're using a hand sanitizer, you're not going to kill the norovirus if it is on you. So you want to wash your hands carefully. And there's actually a blog that talks about hand washing, but think of your hand as having 4 sides. There's the top, the bottom, and then there's the side of your hand and the side of each finger. So you have 4 surfaces to your hand, the top, bottom, and 2 sides. And so when you wash your hands, you want to get the water as hot as you can tolerate it. not so hot that it's going to burn you, but as hot as you can tolerate it. And then use soap and get really, really sudsy. And then rub your hands together. The friction is going to be very important to getting any kind of virus or even bacteria off your hands. So that friction is important. And rub all 4 surfaces, and then pay a close attention to your fingernails, because those viruses can get under and around your fingernails. And then wash all the way up to your wrists. So you want to pull your sleeves back. It's cold, so we've got long sleeves on. Pull those sleeves back and get a good sudsing on your hands. And then you want to continue to scrub your hands for the same amount of time that it would take to sing Happy Birthday twice. So if you sing Happy Birthday to yourself, do it twice while you're washing your hands. Say the alphabet. Don't race through it, but you rub your hands together for quite a long period of time. And make sure, and then use a clean towel to dry your hands off. So in case something was missed by somebody else, you're not now touching the towel and getting the norovirus or any other kind of virus. As I say, the symptoms are very much the same as with flu. They're mostly nausea and vomiting and diarrhea. And so the lining of the stomach and the bowels get inflamed with this norovirus. So that's what causes you to become sick. And it's really just a real debilitating sickness if anybody has it, and it spreads very, very easily. So if you do happen to get nauseated and you're vomiting and you have diarrhea, there's a big chance that you could become dehydrated at any point in time, especially individuals who have any kind of chronic illness or chronic disease. You're going to find any kind of chronic condition, you're going to find you're more susceptible to dehydration. And especially if you have a virus like this norovirus, you can become dehydrated really quickly. The problem is the more you drink, the more that nauseates your stomach, so the more you throw up. So you're going to have to do a careful balancing act to make sure that you're taking in some fluids, but also that you're not just vomiting up even more because the drinking has stimulated more vomiting for you. So some good things are those electrolyte replacement drinks that you can buy in the store. In pediatrics, it's Pedialyte. They also have some electrolyte solutions for adults. That's kind of helpful because it doesn't stimulate quite as much vomiting. You might have to wait until that subsides, but it doesn't quite stimulate that much. Sports drinks that have electrolytes in them are not that helpful in this case, because I know we all have a lot of sports drinks around all the time, but they're not always as helpful because they don't contain all of the electrolytes. So you can get overbalanced because you're vomiting, you're having diarrhea, so you're losing a lot of electrolytes, but when you're drinking sports drinks, you're only replacing some of those electrolytes. Also, a lot of the sports drinks, any of the sugary drinks, any sodas or coffee, tea, they have a lot of caffeine, and so that's going to stimulate your bowel to empty even further. So, avoid caffeine. And any of the sugary drinks that will just pass through and withdraw those electrolytes even further out of your body. So sometimes people are not sure, especially if they have some chronic conditions, when they become dehydrated. And the easiest check for dehydration is just very gently take the skin on the back of one hand and take your other hand and just draw that skin up into what we call a little pinch. Now, you're not actually pinching like you're going to hurt somebody like with a pinch, but just take that fleshy skin on the back of your hand and just draw it up between using your other hand, using your thumb and forefinger. If you're adequately hydrated, that skin will snap right back into place when you let go of your thumb and forefinger. If you're dehydrated, that skin will kind of stand up on its own because the skin's lost its elasticity because you don't have enough fluid in your body. So that's how we check in the hospital. That's how health professionals check. Of course, there are lab tests that can be done, but if you just want a quick, easy, down and dirty test, that's how we actually check people, is we just very gently gather up the skin on the back of a hand and see if it stands up, then we know people need to take a little more water, fluid being a good drink to take in as well. Sometimes you can tell if somebody has a really dry mouth, if they have bad breath, they might be having dehydration. If you look at the urine, it's really bright yellow or dark. That's usually a sign of dehydration. Some people get very tired, or they have a headache when they get dehydrated, or they might have some muscle cramps, spasms. They might get lightheaded when they stand up. Now you'll notice that all these symptoms that I've just been listing are all symptoms that you might have just because you have spinal cord injury or paralysis. So if it's a new onset and you've been having some nausea and vomiting, you'll kind of know that if you're dizzy when you get up, it's probably because you're dehydrated if you haven't been suffering from orthostatic hypotension anyway. If it's a new onset, then you'll know that that's probably what it is. People who are dehydrated can get overheated very easily, and individuals with spinal cord injury oftentimes have problems with overheating their body. It's difficult to maintain body temperature. So if somebody has a red face without fever, or even sometimes you might get a low-grade fever, you might be overheating in your body. So be particularly careful of that. Further on down the road, you might be having some constipation. That takes a while to develop. Whenever somebody doesn't have enough fluid in, the stool becomes much harder because there's just not enough water content in it. So constipation isn't noted right away because, of course, you're having this diarrhea. So you might notice constipation a few days later, so you might want to prepare for that. And if you're having diarrhea, if it's severe, if you're having severe vomiting, you might want to call your health professional if you feel like you're becoming dehydrated, because you are at risk of dehydration. You don't want it to become so severe that you run into a lot of complications. So some people will get the norovirus. They're admitted to the hospital because they're so dehydrated, and they have to have IV fluids to bring their bodies back up into hydration. So it's a very serious illness. Many people get it. They have it. It's a pretty miserable state for a couple of days, and then they get over it. But I think whenever you have any kind of chronic condition, you need to be very wary. So washing your hands is the key here. With soap and water is going to be the key. You cannot do it enough. Anytime you touch something, or if somebody comes into your environment and touches something, you're going to be wanting to wash your hands. So there are some complications. There's an article that just came out, and I just came across it today, and I thought, well, how appropriate, because it's an article. The main author is Michael Stillman. If you happen to know him, he's from the University of Washington School of Medicine in Seattle. And so he is the main author on this article, and it's about the complications of people who have spinal cord injury over the first year of discharge from the inpatient rehabilitation unit. So it's accumulation. He's looked at a lot of charts, and he's looked at what the complications are that most people have in the first year from discharge. And so the number one complication that people generally have is UTI, and I think we can all figure out that has to do with catheterization. So urinary tract infection is the number one complication that most people end up having, and it's usually, most often, it's from poor catheterization technique, which again, you need to wash your hands with soap and water, or if you're catheterizing, you can use a hand sanitizer. That will not kill the norovirus, but if you're just in your general environment, you can go ahead and use a hand sanitizer. sometimes what happens is people just get a little bit sloppy with a catheter insertion, or maybe they touch the catheter before they insert it. Maybe it hits up against a sheet. A lot of times maybe it'll hit up against your thigh, or maybe you miss insertion the first time and people go ahead and use it again the second time, which shouldn't be done because now it's contaminated, so you put germs on the catheter. So there's just a lot of reasons for developing a urinary tract infection. Another one being you might not be drinking enough. So again, that drinking fluids, especially water, is very important. The second common complication that people have is autonomic dysreflexia, and that is one of the issues that we talked about on the blog. And there's several issues that I've been talking about on the blog that people usually have right after their injury while they're in the rehab hospital, or like in this article, the first year out, they develop some of these complications. The interesting thing about these complications is, okay, you deal with these complications, you think, oh good, I finally got this managed and this is taken over. Years go by and you don't have it anymore, and so you're feeling pretty comfortable with what you're doing, and then all of a sudden, boom, it's back. And you're thinking, my goodness, why is this back? I haven't had this for a long, long time. But often what happens is the same complications that we have in the beginning of the spinal cord injury are the same complications that will arise after time has passed, but we have gotten older. Unfortunately, this aging thing comes to us all. So there's just no getting around it. But we can prepare for it, and we can know that we might develop some of these problems that we had early on, or we might develop them when we've never had them before. So there's always all kinds of situations that can arise, but autonomic dysreflexia is generally for people that have injuries above the T4, T6 area. But they can also, you can develop autonomic dysreflexia if you have an injury all the way down to T10. It's pretty rare in those lower thoracic injuries, but it can happen. And the reason why they think currently, nobody really knows why autonomic dysreflexia occurs, but the reason why they think it occurs is right about in that T6 area is a little bundle of nerves in your spinal cord that branch off and run a lot of the heart and the heart beating, do a lot of blood pressure control. So there's this little bundle of nerves right there. So what they're suspecting is that there's some miscommunication because this little bundle of nerves is wrapped together so tightly in that one spot. And that's why somebody has a message coming from the lower parts of the body, and then when it hits about this T6 area or higher, it gets misinterpreted somewhere in this T6 little bundle. And that's why people who have injury above that area, if the T6 is affected, but your injury, say at C4, it's still affecting T6, and so that message can't get translated properly up to your brain. So that's currently what the thought is. So autonomic dysreflexia, if you've ever had it, you certainly know what it is. And it's an immediate onset of high blood pressure. Your nose may feel congested. There's a pounding headache that goes along with it. Your face could get flushed. There's a variety of symptoms that go along with it, those being the most common ones. And so sometimes people think you have to have this real dramatic episode of AD for you to have AD, but a lot of times people have it, but they have such subtle symptoms of AD, or they just have one symptom of AD, like they'll get a stuffy nose. And because they don't have the blood pressure problem, because they don't have the pounding headache, a lot of times people don't equate that to AD. So you can have all the symptoms very severely, or you could even have just one symptom very mildly, or you could have a combination of all of the above, and it's an AD episode. So it is a medical emergency because of the elevated blood pressure. You don't want to have any complications from that. It can usually be resolved by lifting the head up, getting into a sitting position. That will enact, if you sit up quickly, that usually will enact the a person's orthostatic hypotension, so their blood pressure will drop down. And then you can remove the source of the problem. It's usually some kind of bothersome stimuli below your level of injury. Most often it's a kinked catheter or your bladder needs to be cathed. That is the number one reason for stimulating dysreflexia, autonomic dysreflexia. Another indication can be if your bowels become impacted. It could become from diarrhea, from the norovirus. So it's any kind of noxious stimuli can set off these episodes of AD. Some people will have them episodes of AD intermittently, and then some people are kind of constantly plagued with it. If you do have this constant AD triggers that happen very frequently, there is medication that can be taken for that as well. The third common complication is pressure ulcers, and so that is something that I spoke about in the last blog that I posted just for this week about maintaining your skin and checking your positioning. So there's several things that I rolled together in positioning for reducing swelling or edema in your hands and feet or in other parts of your body, reducing pressure ulcers. You can also use positioning to help reduce spasming. And so pressure ulcers develop in the first year as the third major complication, but they can really develop anytime, especially if you become dehydrated and that fluid is not getting to your skin in enough to keep your skin elastic. You know, I told you about that little back of the hand test to test the elasticity of your skin on the back of your hand to see if you're dehydrated. So if you don't have enough fluid in your skin, it's not as elastic and it doesn't have that give and take with your body for movement or pressure of those bony prominences up against your skin. Interestingly enough, in this article, the fourth most common complication of spinal cord injury was bone and soft tissue injury, which a lot of times people don't think about. But this is another issue for positioning. Sometimes people think, oh, I don't feel anything in my legs, so I'll just throw them over on the bed because, you know, I just need to hoist them over there. But your body, even if your brain is not interpreting what your body is feeling, your body is still feeling it. And that's a very important thing to remember. You might not be sensing what's going on, but your body's still going to react to it. So if you slam your leg against the bedpost, you're still going to get a bruise. So the soft tissue injury, that's like things like bruises, minor cuts, scrapes of the skin. If you drag your skin along the sheets, you can get like a rug burn kind of thing, or even a bone fracture if you're not careful with your body parts. So you always need to be just as gentle with your body parts if you're feeling it or if you're not feeling it. It's very important to take care of those things. And then the fifth thing that they noted was bowel complications, such as constipation or impaction or hard stools. That, you know, getting the bowels regulated and finding out what's going to really work for your bowel is very much a trial and effort kind of thing. So it's kind of hard to figure out what you really need to do to keep your bowels functioning. But people usually get into a routine, and certainly by the end of the first year they kind of know what works for them, what foods to avoid so they don't get diarrhea, how often to do their bowel program, how much fiber they need to add. All those kind of things get sorted out. Typically that is not sorted out by the time you leave the rehabilitation facility. It is certainly everybody's desire who's caring for you in the rehabilitation facility that gets sorted out. But you're eating food in the rehabilitation facility, you're probably doing more exercise and therapy than you're doing at home. So your bowels are getting really good input, whereas when you get home, people tend not to exercise as much. Their diet may be different from the food that they had in the rehab hospital. So it takes a little bit of getting used to once you get home and getting those bowels regulated. And of course, we all know that the higher level of injury and people who have complete injuries will tend to have more complications than people who have lower injuries. It doesn't exempt people with lower injuries. It just seems that people with higher level of injuries seem to collect more. And of course with aging, that always is a complication, because you might be going along in your life 20, 30, 40 years, even I've seen people 60 years with spinal cord injury, and they've really managed themselves very well, and then all of a sudden they're dizzy when they get up. Well, why is that? Well, that's that orthostatic hypotension coming, kind of circling around again and coming back, because one day your body changes with aging. It seems like, your body, one's body accommodates for so long, and then all of a sudden the aging process is, an ongoing event, and then just one day it kind of slips up and those aging issues come to us all. So as we get older, we might find, oh gosh, I had some of these things, some of these issues way back early on in my early days of spinal cord injury, and here they are again. It hardly seems fair. Neurological injury has been studied in a variety of different ways. In the 50s was the polio epidemic, and now we're having a whole host of individuals that, since 1950, they had polio, they recovered, they've managed to adapt, they've gone on with their lives, and here it is 60 years later, and all of a sudden they're having complications again, and it's what we call post-polio syndrome, because their body has aged and they're just not able to move around and do the things that they used to be doing. And so maybe it's just become more difficult for them to move around. Maybe they've slowed down in their activities, and so sometimes these things come back later. But, we all, doesn't matter if you have a spinal cord injury or if you don't, aging is going to happen to us all. So we all have to think about these things and become prepared for those kind of things. So let's look at some questions that we have. People have asked some questions on here, and they are fabulous questions. I took a little peek before we started. So we have a person who's written in, and they have a spinal cord injury at T9, T10. And they've had some pain at the area where the spinal cord injury has occurred, and they've taken Neurontin for pain, but without much success. Is there anything you can prescribe to give some pain relief? Well, I can give you some information about pain, and that is, I can tell you that well over 60 to 80% of individuals who have spinal cord injury have chronic pain with that. So that's a wide range, 60 to 80%. But certainly more than half of the people who have spinal cord injury. And it can be from injury or disease. A spinal cord injury can equally be caused from disease as some kind of traumatic accident. So we're always talking about both when we talk about spinal cord injury. That includes trauma and it includes disease. And so this person has been having some problems, and they've been taking Neurontin. Well, if it's a nerve pain issue, there are only two drugs that treat nerve pain directly, and that's Neurontin, and then its predecessor, Lyrica. And so they're both formulated the same. There's just a slight difference in between them. There's not really a difference where some people like Neurontin better and other people like Lyrica better. The Lyrica was developed because Neurontin was on its patent, and its patent ran out, so the price dropped down. So Lyrica has some additional benefits, and it was developed so it could go back on patent, and that's the dirty underbelly of healthcare. But that's the way it works. So if it's a neurological pain, the Neurontin should be able to help. It might be that you need to take a stronger dose. There's a wide range of dosage for Neurontin, and a wide range of dosage for Lyrica as well. And so you might need to up your dose. There are some other drugs that sometimes work if the Neurontin is not, you decided that's not the drug for you. There are some, ironically, some antidepressants that can be taken for nerve pain. Now, they won't treat depression because they're just given in a very small amount. sometimes people say, oh no, I don't have a depression, I don't need an antidepressant. But these are antidepressants that instead of taking like 100 milligrams for depression, you're taking like 10 milligrams of the drug. So it's not really going to affect depression in any way, but these really small doses have seemed to help some with nerve pain. So sometimes pain can be a particularly hard problem to treat because it is so subjective to people's individual feelings about pain. If you were to ask me about a pain I had and said rate it on a scale of 0 to 10, I might be a person who say, oh my goodness, this is a 10, it's the worst pain I've ever had. Somebody else might be having the same amount of pain, but they might be a more stoic type of individual, and they might say, well, it's really a 5, I could get by with it, but it's annoying me all the time. The other thing about pain is it is annoying all the time. It's just relentless, and it can be very fatiguing to deal with that continual pain. So try work with your healthcare professional to use a variety of different medications to see what will help. Sometimes people use a pain pump that they have implanted so that they can take the medication, which is delivered directly into the area where the spinal cord is. It's not into the spinal cord, but it bathes the spinal cord with pain medication. That's a surgical procedure that an implant is put in. It looks kind of like a little pacemaker, but it's for pain. And medication's put in there so you can take higher doses of medication that doesn't have to go through your gut and through your whole system. It's just being delivered right there to the spinal cord area. If the pain's coming from spasticity, there are drugs that you can take. Baclofen can be put into a pain pump. Sometimes they'll use different medications in the pain pump to help control your pain. But there are a variety of oral medications that you can try. And then there are other things that some people, and I just say some people, have had success if they've tried some different kinds of treatments. Like using therapy. Sometimes people can do some stretching exercises or build up the muscle area around a particular location in the body. So this person is having the pain right at the area of where their break occurred. And I will tell you that sometimes in that area we call it the zone of transition, from where you feel to where you have lack of sensation. Sometimes that area can become very painful just from muscle weakness because the muscles below your level of injury are not engaging fully, but the muscles above your level of injury are. So sometimes those muscles get overworked, and they have to be built up so that you have the tolerance to be able to sit and do things, because those muscles are just so overworked. So you really need to work with your healthcare professional to look and see what kind of pain you're having. Maybe you're having a combination of pain. So there's all kinds of things from, yes, this is a nerve pain, to, gee, I need to build up my muscles. Well, that makes sense because the muscles down below aren't working so well. So there's all kinds of things. Sometimes there's just some funny sensations that people have that are pain sensations at that zone of transition from where they're feeling to where they're not feeling. And the funny sensations are interpreted as pain because that's what the body's telling you. So sometimes the body will say, something's wrong right here. And you would like to tell your body, I know something's wrong right there, but your body's not figured it out yet. So there's a lot of things that you can do. So you really want to talk to your healthcare professional about all the different kinds of pain and what you can be doing. Now the next question is from a person who writes in that they have adhesive acroiditis. And so what that is, the arachnoid is the surrounding to the spinal cord, and it's sticking to the canal where the spinal cord's being contained. So it's sticking, it's not directly sticking onto the vertebrae of the bones, but it's sticking to the canal where it's going around in those bones. And so they got this from a medical procedure that didn't go so well, and so he's got a new doctor, and he's wondering if he thinks maybe the doctor isn't prescribing quite the right thing for him. He's being prescribed treatment for swelling of his spine and going to physical therapy. Well, adhesive arachnoiditis, the itis, is swelling. That's what that means. So probably you are getting the right treatment, but if you feel like you're not, or if you're not understanding what they're doing and how that relates, it's always best to go back to your healthcare professional and just tell them, I don't understand how this is supposed to work. Can you give me a simple explanation, or talk to the therapist? Maybe they can explain why do you think this treatment would be ordered. If you're uncomfortable in speaking with the physician because maybe you don't want to feel like you're challenging them, you can have the therapist ask or suggest some treatment that might be better suited for your particular case. If this is a new doctor, so maybe you haven't set a kind of relationship or rapport with this doctor, and you know not everyone is welcoming to questions. People in the healthcare industry, we're used to people asking us why this is this way, and some people just aren't really adept to that. So if you're feeling like you're not working well with your new doctor, you might want to see if you can switch to maybe someone else who you're more comfortable with. Or maybe if you just go and ask them, you just don't want to walk in and demand, I want to know why, you don't want to demand an answer as far as kind of presenting a hostile attitude. You want to go in with, I just don't understand how this is supposed to work. Can you help explain this to me so I can participate more fully in my therapy if I know what I should be doing? So, if you ask with an attitude of, that you're really trying to get help and you're really trying to help yourself, sometimes people are a little bit more amenable to that. But you should have a relationship with your healthcare professional in that you're able to ask them questions, no matter what they think about it. Remember, your healthcare professional has gone to school and they've studied these issues for years and years and years, and to them it's so very clear in their mind. But they need to be able to explain that to you, what's going on. So if you're finding that you call the doctor's office and you say, I just don't quite understand this therapy and how it's going to help and what I need to do to ensure that I'm helping myself. If you're not comfortable in doing that, or you find you're not getting the answers that you require, then you might want to look for a different person to take care of you, because these are just the kind of things that you need to have that give and take with your physician. And then once you get the trust going, and then things kind of ease up a little bit and you get going. Plus you want to let your physician know that you are actively involved in your care, and that's a good way of doing that. Here's a question near and dear to my heart. Is that this person was told to drink plenty of water, so they do, and then they swell up in their legs and feet and sometimes wet themselves. So how do I keep the swelling down? So this is a common problem, because if you read the blog or you listen to the webinar, I'm always drink, 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 because it's so very important. But you can drink too much. So you don't want to just start out one day and just start drinking a tremendous amount of water. You want to build up to it. So most people should be drinking eight glasses of 8 ounces of water a day. That is a lot of water. And if you've not been drinking that much water, to sit down to say, okay, tomorrow I'm going to start drinking my 8 and 8. 8 glasses of water with 8 ounces of fluid in each. And if you just start doing that tomorrow when you haven't been drinking that much, I'm going to tell you, you're going to get real dizzy, and you're going to be a little bit nauseated, because it's just going to be too much all at once. So figure out how much water you're drinking now, and then just add like maybe even a quarter of a cup in between until you eventually build up to that. If you find that you're just getting too overflowed with water, back off a little bit and go a little bit slower until you can build up. So when we don't have movement when people don't have movement in their legs, sometimes you can get a lot of swelling. And the reason for that is that when you're moving your legs, the muscle contractions are big pumps in your legs. You've got big muscles in your legs. And so when you're moving your legs, those pumps are pumping that fluid back up. Your heart is pumping your blood around, and your blood is picking up extra fluid. But when you're not using those muscle pumps to help move that fluid along, people tend to get swelling. If you're not using your arms or hands, you might also notice swelling in your arms and hands because your arm muscle pumps aren't pumping that fluid back. So another thing that you can do to help yourself is to do range of motion exercises. If you can do them yourself, if you can pick up your leg and move your toes back and forth, move your ankles in a circle, take your hands and move them around so that you're moving the joints through all their range. So however they move, you're moving those joints, pushing your foot into a brake position and then pulling your toes towards your nose, and moving your knee back and forth, and also go on up to your hips and move your hips. Now if you're sitting, your hips are going to be in a 90-degree angle. So when you get out of your chair, you don't want to lay with your legs flexed all the time. You can position on your side with a bent leg, but sometimes you just need to lay flat on your back to straighten out those hips. Or even if you are able to lay on your stomach and kind of stretch your hip muscles out a little bit, that really helps a lot too. But that is a whole other thing, because you want to be careful about laying prone if you're having any kind of breathing problems, because the weight of your body is different when you're on your stomach, and it's harder to breathe on your stomach because your stomach and your chest are being compressed by your body weight up against the mattress. So anyway, think about moving your extremities. If you can't do it, have someone do it for you. You can also wear a compression hose. If you have some of those left over, you can get them not too inexpensively at the big box store or at a drug store. They are a little bit pricey, but you can also use ACE wraps. Always wrap from the furthest part of your body towards the heart. Never go the other way, because that captures the fluid in your extremities. So you can do a variety of things to help relieve those. You can put your legs up higher than your heart, which will help the fluid return back to your body and out. And if you're wet in between, you can think about, if you're catheterizing every 5 to 6 hours, maybe catheterize every 4 hours. So kind of keep a little log to keep track how long it is until you're wet. We don't want people catheterizing much more than every 4 hours. Now I know some of you out there probably do, and if you have instruction from your health care professional, do what your health care professional says. But we usually keep catheterization at no more than every 4 hours to cut down on the number of infections, the number of times that catheter is inserted into the bladder. And so every 4 hours is kind of like our arbitrary cutoff for that. So if you're having that much trouble, think about some compression stockings. If you can stop in the middle of the day and put your feet up sometime. Now, if you're putting your feet, or if you have edema in your hands and arms and you're putting them up higher than your heart, the fluid's going to run to the lowest point of your body. So sometimes people get in bed, they put their feet up, and we usually tell people to catheterize maybe like a half an hour or an hour after they lay down in bed, because when they put their feet up, that fluid's coming back up and out of their body, and so you usually have to catheterize within a half an hour after going to bed. So you want to coordinate all of that. But sometimes that fluid will run up and collect like in your lower back. So be sure and examine your back and see if you press on your lower back, if it's looking kind of like a bowl of jelly, it's probably full of fluid. So sometimes people have to take medication to get their fluid out, But that's usually a much further down the line kind of thing. I only tell you so because, we're into talking about aging, and so the fluid might not flow out as well as it did when you were younger. So just keep on top of that, but you're all inspecting your skin all the time anyway. So look, you can't look around and see the backside of your body, but if you have a long-handled mirror you can see, or with the advent of everybody having a cell phone these days, you can go ahead and reach around, take a selfie of your backside, and just have a look at that and see what's going on with your skin, if there's any edema, any rashes developing. It's just a good idea. You don't need to send those pictures to anybody. They're your private. You can delete them off your phone. So it's just a great chronicle to have. We have another question about a person who has a T12 paracomplete, and they're having some gallbladder attacks due to stones. So this is an interesting thing because the stones are small, so they're passing through. When people have problems with their stones is when they get large enough and they cut off the gallbladder, or they enter into the ducts of the liver, and so the bile can't pass through there and it gets backed up. That's when you have one of these gallbladder attacks. Now at T12, you're probably going to sense a gallbladder attack. Should you have one, you're going to have that feeling. If you have an injury above T12, or if you have a higher level injury, you might not know when you have a gallbladder attack because you don't have sensation there. Gallbladder attacks are usually accompanied by pain, and so you might not have that pain sensation. So, but you might have shoulder pain. So a lot of times, if the body can't interpret the pain that's going on below the level of injury, it will still send out those nerve responses, but they'll get miscommunicated. And so oftentimes people get referred pain in the right shoulder blade. So if you happen to have a problem there that's not muscle pain, not something that you normally have, it's some new onset of severe pain in your right shoulder blade, that's usually the way that gallbladder, appendicitis, those kind of things, any kind of problems in your gut are usually looked for when you have that right shoulder pain, hopefully before you get that far. So anyway, that's something to be alerted to for people who have a higher level of injury. So speak to your healthcare professional. You might want to talk to them about having the gallbladder removed if there are stones in there, having it removed before it ends up to be problems. There's risk and benefits to everything. I am always not an advocate of surgery, but if it's going to save you immense problems down the line, that's one of the times that you need to have it done. Because you have a spinal cord injury, it's always good to talk to people about how your case would be handled, how your anesthesia will be handled. In years past, people would have surgery, and the surgeon would say, well, you don't feel there, so we'll just do the operation because you won't feel it. Oh, my gosh, but your body still reacts to it. Your body is still going to react, so you still need the same kind of anesthesia, or you need some sort of anesthesia, or sometimes they can do a spinal anesthesia just to, if you don't want to have the upper respiratory problems. Certainly some relaxing medicine so you're not awake while all this is going on. So you still need to talk to your doctor about all of that. And then before it's an emergency, this is a good time to talk to your surgeon and say, what would be the risk of me having the surgery now versus should I wait, and find out what's unique to you in your case and what would be the risk and what would be the benefit for you. So you can't really ask, your friend who has a spinal cord injury, you can't really ask somebody else. It has to be really specific to you if you want to take the risk of surgery, because there are always risks. You also want to talk to, maybe take a visit and talk to the nurse manager where you will be after your surgery to make sure that they are aware of your needs of turning, since you won't be able to turn yourself right after surgery while you're waking up, to make sure that if you're doing intermittent cath, that somebody is doing that for you, or how they're going to handle your bowels. What about returning to eating and all those kind of things? If you have any respiratory problems that you might need special respiratory treatment, all of those kind of things, talk to your physician, talk to your surgeon, and it's a good idea. I get a lot of people who go to the general hospital and they'll say, Linda, I was in the general hospital and they didn't know what to do with me. Spinal cord injury, when you have it, it's as common as the day is long. Other people who have it. You go to the doctor, people are there that have a spinal cord injury. But when you go out into the general world of healthcare, it's really kind of a rare thing. So sometimes it's not so common that people will know about how to take care of you specifically. It's good if your caretaker can be there, or if somebody doesn't have to sit at your bedside, but if they're there just to kind of, get things started and get things, supervised so that people will know what to do. Okay, another question is, how do you get a doctor at a hospital to take you seriously when you're having an AD episode? As I say, in the general healthcare world out there, spinal cord injury is not that common. Knowing about AD might not be that common. The people who are caring for you in a general hospital setting maybe saw somebody with spinal cord injury in their training, and maybe they haven't seen anybody with spinal cord injury since. The wonderful thing is the Christopher and Dana Reeve Paralysis Foundation has an AD card. It's a wallet card. You can get it right off the internet, right off their page there. They have a series of these pocket cards, or these wallet cards, and they fit right into your wallet. They're the size of a dollar bill, but they're a trifold, so you can just carry it with you. And they have information about what AD is. They have diagnostic information. The card contains usual treatment guidelines, and information where the healthcare professional can contact or get evidence-based information about why this is so. So there's a lot of information on there. Be sure and take the pocket card with you because it is a wonderful conversation starter. And if you pull that information out and you say, I've got this card, and you start looking over the signs and symptoms of AD, and you say, I have this symptoms and this symptom, there's a place where you should write your normal average blood pressure. When you just go for a regular doctor's visit, find out what your normal blood pressure is. Most people who have spinal cord injury have a blood pressure that's lower than normal. So when you hit a normal blood pressure, it's really high for you. So if you go to the hospital and somebody takes your blood pressure, 120/80, well, you're normal. What's the problem? And you say, well, usually my blood pressure is more like 75/50. And they'll be like, whoa, I didn't even know that blood pressure could exist. Well, yeah, it does in me. So it's a good conversation starter. So know what your normal blood pressure is so they can recognize that you're having a high blood pressure. And then take that with you. Keep it with you so that if you're having AD, it really is a good tip-off, and it's worked wonderfully well for lots of people. And there are other cards, too, that you can look up information and keep with you. So there's a series of pocket cards that you can take with you if you're having any of these problems. Okay, there's another question about a person with C5-6, and they're frequently getting flu and pneumonia with hospitalizations and with antibiotics. And of course, we all worry about taking too much antibiotics, but if you have pneumonia, you need to take an antibiotic to get rid of it. So it's good to take an antibiotic before things get too bad, so you can take what's called a lower level of antibiotic instead of one of these real advanced antibiotics. So there are infections out there. You hear about them on your TV for which there are no antibiotics that will treat that infection, and that's very frightening to everyone. So we want to keep keep your illnesses from developing into one of these extreme superbugs, as they call them, that you need these high-level antibiotics. So what can you do to help at C5-6? There are things you can do. One of the simplest things is to cough and deep breathe. At C5-6, I'm assuming there's not a ventilator here. And so doing your coughing and deep breathing exercises is important to do. So if you take in air way down as deep as you can, just do it 2 or 3 times, it's probably automatically going to produce a cough. And so it might be a very weak cough, but keep doing it as much as you can, and changing positions, doing your skin pressure releases so that you are turning from side to side. That gets any secretions in your lungs that may be collecting, gets them moving from side to side. If you do have a lot of secretions, you might want to talk to somebody about doing suctioning. Suctioning is kind of harsh. If anybody's had suctioning who has sensation, it's kind of it kind of takes away your breath while the suction's working, and it's kind of harsh. There is a thing called an insufflator. That's kind of a big word. It's called an insufflator. And it's a machine that you don't put a suction tube down the patient, but it just kind of draws out. It's like a mask that you wear temporarily just while you're doing the treatment. It's not worn all the time. And so it expands your lungs and it draws out this fluid. Christopher Reeve had one, and he was very successful with this. He was on the ventilator, but he also used this. And so it kept, just kind of kept his airway clear and his lungs clean. That's something you can do. And then also moving, another thing is in using those fluids. So be sure that you are having enough fluids that breaks up some of the mucus in your lungs. I would not recommend this without talking to your healthcare professional. Some people take different medications that help expectorate fluids or release the mucus in your lungs. So you might want to talk with your healthcare professional about that if you're having a lot of fluids. So there are several things you can do. One is to cough and deep breathe at regular intervals, maybe like every couple of hours. If you have an incentive spirometer from the hospital, everybody gets one. Nobody uses it. It is one of the best little devices that can possibly be to get air into your lungs and get those mucus, get that mucus flowing around in there. So find your incentive spirometer and use it several times a day, even every couple hours while you're having any respiratory problems. I've used them frequently, and somebody goes to bed and they're having a little bit of fever, they're have a little bit of congestion in their chest. I've used them with patients when I've worked on the night shift, waking them up. They don't enjoy waking up, but by the next morning the fever's gone and their chest is clear. If you're having problems with respiratory issues in the night, it's a good idea to go ahead and do that as best you can with if you have somebody who can help you get that going, or keep it in bed with you so you can do that. The reason being that when you're at night, you're laying there and those secretions are pooling and you're not moving around as much as you are during the day. So just something to think about. The fluids, coughing and deep breathing, changing your positions are going to be the big things that is going to help reduce your pneumonia. And of course having your caretakers wash their hands, as well as not sneezing or coughing on you, which hopefully they aren't doing, but sometimes things happen. This person is also looking for specialists on mattress overlays and other mattress options for a better sleep. So sleeping on one side. There are so many mattress type overlays. You know what I would do, Douglas, if I were you? I would educate myself first, and I would just go online and look for mattress overlays or specialty mattresses and get a good idea of what's out there. There are just a variety of kinds. Some are more advanced than others. And so kind of get in line what you might be thinking, and then I would talk to your case manager who would be working with your insurance company or your payer. If you don't have a case manager, ask your payer to be assigned one, because they will be the person that will be helping you get the finances to pay for this. The other thing is to talk to your healthcare professional and see what they would recommend. There are mattress overlays, and there are mattresses that are pressure dispersing, so they disperse pressure so that you don't have so much pressure over your bony prominences. You still have to be turned. There are mattresses that have air that move throughout the mattress, which helps take pressure off one area and move it to move that pressure around. You still have to be turned. No matter what you have, you still have to be turned. These things are not magic bullets, but they can certainly help. And especially if you're having trouble and can only sleep on one side, that's pretty miserable to lay there and not being able to move around, because you've got to release that pressure on your skin. Plus your body, even though you're not feeling, is saying, get off of me, I want to turn. People turn thousands of times. They have slight little movements that they're adjusting their bodies at all times, and especially at night. So educate yourself. Just look it up and you'll just get a whole listing of mattresses. Kind of try to figure what you think might work for you, and then talk to people who can get these items for you. Douglas, you need better sleep. You need to be able to turn and move around while you're sleeping. So I think you're on top of it. Thanks for asking that, Douglas. There's another question about somebody, after sitting their feet it appears red mainly on the toes and on the top. It goes away when the legs are elevated. Is this cause for concern? Well, something's happening in the circulation of your feet, and so it's sounding like it might be a shoe kind of thing, like if your shoes maybe are too tight, or if you're wearing athletic shoes, if they're tied too tightly. Since it's on the top and not on the bottom but on the toes, I'm thinking it's a functional problem with your shoes. So you might want to look, maybe you need a little bit larger size. As long as it's going away, that's particularly good, and when the legs are elevated, so it might be some little form of edema that you're getting. So the blood's pooling down there for some particular reason, and you don't want to get the blood pooling and develop a blood clot down in those little tiny vessels down there in the feet. So keep elevating your legs. You might want to try some compression stockings if that blood is not returning. You will want to see your healthcare professional before trying the compression stockings, because it could be that your feet are turning red because of some other kind of circulation problem, in which case it would be contraindicated to have the extra pressure of the stockings on there. So go to your healthcare professional. Be sure that you've been sitting for a while, and be sure that you have your normal shoes on, so that when you take them off you can say, oh yes, this is what this is. So your doctor will be able to see it. We have somebody, our friend here is also looking for commode shower chairs to reduce hemorrhoids. And that is a huge problem, because when you're sitting on it, you're basically sitting on a donut, which is allowing the hemorrhoids to occur. So the problem is to try to get your bowel program adjusted so that you're not sitting that long, and be sure you have well lubricated your suppository and your gloved finger so that you can do the digital stim. And he's having some AD. If your bowels are moving all night, you need to look at your bowel program. You should be able to do your bowel program in a much shorter, it shouldn't take all night. It should take maybe 20 minutes. In an ideal world. Now, everybody listening to this says, my bowel program doesn't take that long. But you need to think about maybe adding some fiber, or maybe doing a bowel program every day instead of every other day, because your bowel's moving tonight all night long. That's too long. Maybe the suppository you're using is too aggressive for your particular bowel. So I think we better end there, because time is up. But these have been some wonderful questions, and so I'm happy that we had this time together, and I wish everyone a great week.
Yes, I'd like to thank everybody for joining us today. Hopefully we got to everybody's questions. If not, please join us again next month for our live chat with Nurse Linda. You may also leave her a message on our online community, and she will at christopherreeve.org/nurse. She's live in our online community every Wednesday from 8 to 9 p.m., so she will answer your questions there as well. And I hope everybody has a good rest of their day. Thanks so much for joining us. Bye.
Have a great day. Thank you. Bye.
Ladies and gentlemen, that does conclude today's webinar. We thank you for your participation and ask that you please disconnect your line.